Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. C. Sarath Kumar sir. Sir has done MS, PhD, super specialty in sexuology and infertility. Dr. Sarath Men's Clinic, Director, Mediwave Fertility Research Hospital. Today, sir is going to speak on a topic, Physiology of Penile Erection. Let me tell you overview of the topic. Penile erection is a complex physiological a process that plays a vital role in sexual function and reproduction. It involves an erectile interaction between the nervous, vascular, and endocrine system. Therefore, understanding the physiology of penile erection is a crucial for comprehending the mechanism of underlying erectile dysfunction and developing effective treatment strategies. To know about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you for us. Good afternoon, all my esteemed colleagues. This afternoon, I am going to talk to you on the physiology of penile erection. Of course, everybody will be anxious to know, not only the general public, even the doctors will be knowing, will be anxious to know how actually erection occurs, how actually penis becomes rigid from a soft tissue, how it becomes a hard tissue. So this topic this afternoon I am going to cover in the following chapters. Of course, with an introduction I'll start and I'll just briefly touch upon the male reproductive system parts and the parts of the penis and functions of the penis, erectile tissue in detail, and physiology of erection, the types of erection, and sexual dysfunction in brief. So these are the chapters I am going to cover this afternoon. Let me start with the penis, the erectile tissue. What are the erectile tissues which are there present in the penis? The erectile tissues are three. Two corpora cavernosa. What you are seeing in the green shade are the corpora cavernosa. What you are seeing in the yellow one is the corpus spongosa. The corpus spongosa expands itself at the tip of the penis as glans penis. So these are the three main erectile tissues which are present in the penis. The erectile tissues fill with the blood during sexual arousal, producing an erection. The root and body of the penis are spanned by three masses of erectile tissue. So in the picture, you can clearly see the three erectile tissues. And what is seen on the right side is the cross section of the penis. You can see the two corpora cavernosa, greenish shade, and one yellowish shade, that is corpus spongosa. Urethra passes through the corpus spongosa. And erectile tissue can be divided into three parts: the root, the bulb, and the crura. The left and right crura and the bulb of the penis. Bulb is situated in the root midline of the penile root and is traversed by the urethra. Crura, there are two crura, right and left. They are located laterally, attached to the ipsilateral ischium ramus and covered by the paired ischiocavernosal muscles. So the crura are attached to the pubic symphysis by these crura. And of course, penis is covered by prepuce. In the prepuce will be circumscribed in several religions before the age of 7 or 8 years itself. And in Hindu population, it is not circumscribed routinely. The prepuce envelops the glans as a variant of mucocutaneous tissue presenting with a lot of functions. The functions of the prepuce are: it protects the glands from feces and ammonia during infancy and childhood, and also it protects the glands from abrasions and trauma throughout the life. It provides sufficient skin in the erection. And coming to the functions of the penis, of course, there are two main functions. One is, of course, sexual intercourse, and another is micturition. Coming to the sexual intercourse, the penis becomes erect. It is an erectile tissue. When a person experiences arousal, the penis fills with blood, causing an erection. Erectile function is closely related to cardiovascular health. Rigidity of the erection enables a person to penetrate a partner and have sex, whether it is oral penetration or anal penetration or vaginal penetration. The rigidity is a must during sexual intercourse. And another function is the reproduction. That is, it ejaculates. The semen is ejaculated through the penis, through the urethra. The following sexual activity or manual stimulation, a person can then ejaculate. After ejaculation or loss of arousal, penis returns to a flaccid state. You can see in the picture how the penis has entered the vagina and is ejaculating into the deep into the vagina, that is into the surrounding the cervix, and the sperms then swim up the uterus from this part, that is the innermost part of the vagina, that is vagino-cervical junction. There the actual intercourse, at the time of intercourse, the semen is deposited in this pouch. The another function of the penis is micturition. Penis contains urethra, which allows passage of the urine from the bladder to the urethral opening, enabling a person to expel the urine from the body. So this is how you can see the urinary bladder in the picture. And also you can see the junction, that is junction between the urethra and the bladder. And of course you can see the prostatic part of the urethra, and you can see the membranous part of the urethra, and you can see the spongy portion of the penis where the urethra passes through the corpus spongiosum. And you can see the glans penis and external orifice of the urethra where the penis outside the body of the this one, the urine comes out from the tip of the penis. So now coming to the topic of the day, that is the physiology of erection. How actually the erection occurs. During an erection, the emissary veins are compressed between the sinusoids and tunica albuginea to limit venous drainage from the sinusoids and maintain a tumescence. What happens during the erection is the blood which is going into the spongy portions of the penis, that is corpus cavernosa and corpus spongiosa, will not return back, and it will be during the emissary veins are compressed between the sinusoids and tunica albuginea and limit the venous drainage. In other words, the blood is flowing into the penis, but the return is blocked. You can see in the picture how the blood has entered this one and how the emissary veins are compressed so that this one is not coming, and there will be accumulation of lot of blood in the sinusoids of the corpus cavernosa and corpus spongiosa, and the pressure increases in the penis. Once the pressure increases in the penis, the blood is flowing in, but it is not coming out. So erection occurs and rigidity will also come. And how ejaculation occurs. Engorgement of the corpus spongiosum constrict the pressurizes the urethral lumen to allow forceful ejaculation. So what actually happens is the urethra, the cystourethral junction is narrow, and the semen, which is coming from the prostatic part of the urethra and seminal vesicle from the common ejaculatory duct, will not go back. It will come forwards, and that will be prevented by constriction of the vesicourethral junction. And what are the muscles? There are two muscles, bulbospongius muscle and ischiocavernous muscle. They surround the bulb of the penis and forces additional blood into the penis during the rigid erection phase. So it is not only the spongy portions of the corpus cavernosa and corpus spongiosa which help to maintain the erection. The two muscles, the bundles of muscles, that is paired muscles, bulbospongius muscles and ischiocavernous muscles, they surround the bulb of the penis and they force additional blood into the penis by their constricting action, and they maintain the rigidity of the erection. They won't allow the blood to go back. They constrict and hold the bulb in such a way that the blood is retained in the penis. That's how the erection is maintained. And the penile erectile tissue, specifically corpus cavernosa, the smooth muscles and the smooth muscles of the arteriolar and arterial walls plays a key role in the erectile process. What happens is during erection phase, the smooth muscles of the blood vessels, that is arteries and arteriolars in the penis, they expand, they relax, so that lot of blood is collected in the sinusoids. You can see the two pictures. In the flaccid phase, and in the erect phase. In the flaccid phase, you can see that the corpus cavernosa collapse, and in the erected the picture, you can see lot of sinusoids, that is blood-filled spaces, which within the corpus cavernosa and corpus spongiosum. This is possible only by smooth muscle relaxation of the blood vessels, that is arteries and arterioles, and also constriction of the vein, which will not allow the blood to go back into the stream. In the flaccid state, the smooth muscles are tonically contracted, allowing only small amount of the arterial flow for nutritional purposes. The arterial partial pressure of the oxygen is about 35 mm. The flaccid penis is in a moderate state of contraction, as evidenced by further shrinkage in the cold weather or after injecting phenylephrine injection. So, in the flaccid phase, there will be blood flow, but that flow is enough only to maintain the healthy tissue of the penis. So, no rigidity will occur during the passive phase. When there is sexual stimulation, it triggers the release of neurotransmitters from the cavernous nerve terminals. This results in relaxation of the smooth muscles, and the following events occur: that is, dilatation of the arterioles and arteries by increased blood flow in both diastolic and systolic phases. So during erection, what exactly happens is there is stimulation by neurotransmitters from the cavernous nerve. And once there is stimulation, the smooth muscles of the arterioles and arterioles, they relax, and there is increased blood flow into these spaces, and there is expansion of the spongy tissue that results in the increase in the size of the penis. And trapping of the incoming blood flow by the expanding sinusoids. Once the sinusoids expand, what exactly happens is the veins which are situated between the spongy tissue and the tunica, they are constricted, and this constriction makes the blood to get trapped in the spongiosal tissue so that it won't return to the stream. The compression of the subtunica venular plexus between the tunica albuginea and the peripheral sinusoids reduce the venous flow. So, friends, there is increased blood supply to the penis, and it expands the spongy tissue, but at the same time, it won't allow all the blood to go back to the stream because the vein is constricted. That is, in other words, the blood is trapped. It is trapped in the spongy tissue, making the penis rigid and erected. Stretching of the tunica to its capacity, which occludes the emissary vein between inner circular and outer longitudinal layers, and further decreases the venous flow to a maximum extent. You can see in the picture how the spongy tissues have totally they have expanded, and you can also see the vein which is compressed. You can between the tunica and the expanded spongy tissue. An increase in the pressure of the oxygen to about 99, and intracavernous pressure, that is around 100 mg, which raises the penis from the dependent position to the erect state. So it is nothing but increased pressure, just like blowing a balloon. When you blow a balloon, the balloon expands, and also the balloon is a linear one, it gets erected also, it expands. A further pressure increased to the several hundreds of millimeters of mercury with contraction of the ischiocavernous muscles make the penis rigid. In other words, intracavernosal pressure increases so much that it becomes rigid. And the ischiocavernous muscles, they also contract and make the penis more rigid. So bulbocavernous reflex, depending on the intensity and nature of the genital stimulation, several spinal cord reflexes can be elicited by stimulation of the genitalia. The best known is the bulbocavernous reflex, which is the basis of genital neurological examination and electrophysiological latency testing. So this function of the bulbocavernous reflex is used for genital neurological examination also, and also electrophysiological latency, and also this reflex is used for ejaculation also by stimulating this bulbocavernous muscle by electric shocks. So cerebral impulses normally travel through sympathetic nerves, parasympathetic nerves, and somatic nerves. So sympathetic nerves, they are inhibiting the norepinephrine release. Parasympathetic nerves, they release the nitrous oxide and acetylcholine. And somatic nerves, they release the acetylcholine pathways to produce a normal rigid. So friends, the nervous system plays a very important role in the erection. And these are the three systems, that is a sympathetic nervous system, parasympathetic nervous system, and somatic nervous system. All the three nerves plays an important role in the maintaining the in causing the erection as well as maintaining the erection. And in the picture you can see the brain and also what all the parts which are involved in the erection. So angle of the penis during erection, if it is anything between 45 to 90, it is perfectly okay for achieving the insertion. And sometimes it will be even more, 90, 120, even 180 degree rise may be there. The angle of erection is determined by its size and attachment to the pubioscaal rami and the anterior surface of the pubic bone and suspensory and fusiform ligaments. If the ligaments weak, then the erection may not be that rigid and the angle may drop down from the 90-degree to the 30-degree or even 45-degree. In men with long and heavy penis or loose suspensory ligaments, the angle usually will not be greater than 90 degrees, even with full rigidity. So, for the purpose of intercourse, the angle of erection plays an important role. If it is anywhere between 60 degree to 120 degree, that is 60, 90 or 120, insertion of the penis is very easy. And if it is below 30 degree, then insertion may be difficult and insertion may be slightly difficult because the angle may not be suitable for the vaginal insertion. But of course, insertion can be done with alignment, that is coital alignment technique. So men who have got the erection above 120 degree and below 30 degree, they may have to manipulate with hand to insert the penis into the vagina. Otherwise, it may be difficult for the penis itself to enter the vagina because the vaginal angle may not be suitable for the penis entry. And the cooperation of the female partner is also very important in this aspect. By perfect coital alignment, that is penis vaginal alignment technique, she can try to take the penis inside even when the penis angle is below 30 degree or above 120 degree. So after erection, it is detumescence. Detumescence is that is reduction in the size of the penis after the ejaculation is over. That is returning of the penis to its original size. That takes place in three phases. That is in transience phase, intracorporeal pressure increase, indicating beginning of the smooth muscle contraction against a closed venous system, and slow pressure decrease suggests to slow reopening of the venous channels with resumption of the basal level of the arterial flow. Fast pressure decrease with fully restored venous outflow capacity. So once the target of sexual job is over, that is either after masturbation or after intercourse, maybe of any type of intercourse, vaginal, oral, or anal, or even with the same partner, that is homosexuality. Once the job of the penis is over, it returns to its original size and shape by detumescence. That can occur in the several phases. The first thing what happens is the veins which are constricted, they start relaxing. The ischio-cavernous and the ischio-bulbo-cavernous muscles, they relax, leaving the trapped blood to enter back into the stream. So the one thing which occurs is during detumescence is the veins open up so that the blood flows back into the system. And the spongious tissues, that is the arterioles and arteries, which are expanded, the sinusoids which are expanded, they constrict and they push back the blood trapped in the corpus cavernosa back to the mainstream. So this is the physiology of detumescence. So there are several in the brain there are several segments which are activation regions. The main brain activation centers are bilateral inferior temporal cortex, right ungula, right inferior frontal cortex, left arterial or cingulate cortex, right optical gyrus, right thalamus, and left caudate. So these are the regions or the centers which take an active role during the erection, and their functions are like this. Bilateral inferior temporal cortex, it controls visual association area, that is, whatever the man sees, it is converted into a visual stimulation, causing erection when the person is excited looking at the sexual organs of the partner, or a blue film, or a video, or a sexy scene like that. That is, the bilateral inferior temporal cortex plays an important role in visual association of the erectile function. The right insula, it processes somatosensory information with motivational states. Right inferior frontal cortex, it processes sensory information, that is by touch or any sort of sensation. That sensory touch information goes to the brain. Suppose a man, during sexual intercourse phase, if he touches the vagina or the buttocks or the any sexually arousal organ like breast, he gets the sensory stimulation transferred from his hands into the brain, that goes to the right inferior frontal cortex, and the brain says that you are touching a sensory, that is a sensitive organ, sexually sensitive organ, and it causes the erection. The left anterior cingulate cortex, it controls the autonomic and neuroendocrine function. Right occipital gyrus, again, controls the visual processing. Right hypothalamus, it controls the male copulatory behavior. That is the how the person gets engaged into the coital situation. Left caudate, that is striatum, it gives attentional processing, responsiveness to new environmental stimuli. So, friends, these are some of the brain centers which function to stimulate a person to get erection, and it is associated with all these things. So, coming to the types of erection, there are several types of erections: psychogenic erection, reflexogenic erection, nocturnal erection, vacuum pump induced erection, drug induced erection, and painful erection, priapism. So, we have got five types of erections. Let us go through one by one. First one is psychogenic erection. Psychogenic erection is a result of audiovisual stimuli or fantasy. The impulses from the brain modulate spinal erection to activate the erectile process. So the psychogenic is what the person thinks and what the mind thinks, and it comes from the brain. It modulates, and the spinal erection centers, that is T11 to T12, S2 to L4, S4, to activate the erectile function. Here, the fantasy plays an important role. The imagination and looking at a sexually stimulating object, or a lady or a partner, and audio, we are listening to some sexual words, or a song which is full of sexual this one, or any conversation involved with the sexual activity. That is, that audio or visual, they stimulate, and it may create fantasy also. This is the that causes the erection. So here psychological part plays a major important role. The second one is reflexogenic erection. Reflexogenic erection is produced by tactile stimuli to the genital organs. The impulses reach the spinal erection center. Some of them follow the ascending track, resulting in sensory perception, while others activate the autonomic nuclei to send messages via cavernous muscles to the penis to induce erection. This type of erection is preserved in patients with upper spinal cord injury. So, this reflexogenic erection is produced by tactile stimulation, by touching the genital organ, and this is preserved in patients with upper spinal cord injury, because it is coming from the reflex. The third is nocturnal erection. Nocturnal erection occurs mostly during rapid eye movement during the sleep. The PET scanning of humans in rapid eye movement sleep show increased activity of pontine area, amygdalas, and anterior cingulate gyrus, but decreased activity in the prefrontal and parietal cortex. The mechanism that triggers REM sleep is located in pontine reticular formation. During REM sleep, cholinergic neurons in the lateral pontine tegmentum are activated while adrenergic neurons in the locus coeruleus and serotonergic neurons in the midbrain raphe are silent. This differential activities may be responsible for nocturnal erection during the REM sleep. In fact, for checking up the EEDs, the stamp test or any test which involves the erection during the night involves the nocturnal erection. Most of the healthy individuals will have 6 to 8 times erection during the night, and most of them they occur during the rapid eye movement level of the sleeping. The spinal cord lesions in patients with spinal cord lesion, cerebral impulses can still travel by means of the sympathetic pathway to inhibit the norepinephrine release, and nitrous oxide and acetylcholine can still be released through the synapses with postganglionic parasympathetic and somatic neurons. So even when there is a spinal cord lesion, one can get erection through the sympathetic pathways from the cerebral impulses. So just because one person has got spinal cord lesion, it doesn't mean that there will be total loss of erection. There may be erection by the other pathways, that is sympathetic pathway to inhibit the norepinephrine release, and nitrous oxide and acetylcholine can still be released through synapse with postganglionic parasympathetic and somatic neurons. In the picture, you can see there is a lesion in the spinal cord one between L1 and L5, but still the person can get erection from sexual stimuli, visual, olfactory, or tactile, and it goes directly to the pelvic plexus through the sympathetic pathways, and there may be smooth muscle relaxation by endothelial cell derived from the nitrous oxide, and the PDFI inhibitors still act when there is spinal cord lesion. So, friends, coming to the pathology of the penile erection, till now we discussed about the physiology of the penile erection. There will be sexual dysfunction and impairment of any of the above factors. What causes the erection can result in impairment of bulbocavernosal and ischiocavernosal muscles. It may impair the penile erection. The significance of obtaining a bulbocavernosal reflex in overall sexual stimulation assessment is controversial. And coming to the vacuum pump induced erection, in the vacuum pump induced erection, the blood will enter the penis by creating a vacuum from the vacuum pump, and the blood which enters the penis by passive method, that is by creating vacuum into the bulb of the vacuum machine, the penis expands, and the blood which enters the penis, it will be trapped in the penis by a constricting device which will be put into the base of the penis after the erection is achieved. That is called as vasoconstrictive device. So this type of erection is an artificial erection induced by creating vacuum into the penis and stopping the blood flow back into the system by constricting the veins by a silicone or a rubber band. Look at it, that is by a vasoconstrictive device which will be applied to the base of the penis. Here, the temperature of the penis will be slightly less than the body temperature because the erection is a cold erection. It is not a warm erection, just like a natural erection, and the rigidity may not be up to the level expected in the natural erection. It may be slightly lesser than the natural erection. So, this vacuum induced erection can help a person to overcome the erectile dysfunction and perform the intercourse because the penis attains the erection up to an extent of grade 3 or 4, that is up to 60 to 80% erection will be there, and it may be enough to penetrate the vagina because of the rigidity. And since vasoconstrictive device is applied to the base of the penis, the blood will not immediately gush back to the system. Person can continue to have erection, ejaculate it, After the ejaculation is over, you can remove the penis and remove the silicone band, that is vasoconstrictive device, which has been applied to the base of the penis. The next type of erection, that is the fifth type, is the drug-induced erection. So people who doesn't have this normal physiological erection, they may go for the drug-induced erections. The drug used mainly are PDE5 inhibitors. That is the mainly what we use. That is sildenafil citrate, earlier called as induced by the earlier introduced by Pfizer as Viagra. Now hundreds of brands of manufacturers have come out with various brand name, that is Cavata, Pellagra, Zilagra, like that. Most of them, they contain sildenafil citrate. And once the sildenafil citrate is given, it inhibits the PD5 inhibitors. It is inhibits this one and causes the erection by increasing the nitrous oxide release from the soft tissues of the cavernous cavernosa. So other drugs used, oral tablets like the tadalafil, avanafil, udinafil, they are also useful to induce the erection. And most important thing with drug-induced erection is the physical stimulation is required for drug-induced erection, and there should be the audiovisual stimulation through the brain to see that the drugs induce the erection. Drugs themselves, they don't work unless there is stimulation from the brain also. The other type of drug-induced erections are they give the injection erections. That is injection, that is PG1 injection or phentolamine, or the other drugs may be injected into the papaverine, can be injected to the penis. They cause local vasodilatation and cause rigid erection. They can be used for the people who have severe sexual erectile dysfunction. Those who don't respond to the drug induced erection, they can use these injectables, and these injections have to be taken 5 to 10 minutes before the intercourse. And after the intercourse, usually detumescence occur, and the penis returns to the normal stage about 15 to 20 minutes after the intercourse is over. And also there are certain types of vasoactive gels, that is PDE gel. The gel or cream can be applied through the urethra, that is muse, that is medically induced erection can be done by putting these gels into the urethra. They are absorbed and locally the vasodilation occurs and the penis becomes rigid. That is, these are the drug induced erections. And the last type of erection is painful erection, that is priapism. In this case, the erection occurs, but detumescence doesn't occur. Even after ejaculation, after the masturbation, or even after the sexual intercourse, even after the job of the penis is over, the penis will not return back to its original size. The erection continues. If the erection continues for more than 4 hours, then it is called as priapism, and it will be painful because the continued rigidity, it will cause the pain in the penis. It's a medical emergency. It has to be immediately reduced. And if the priapism continues for more than 4 hours, then the sympathetic, parasympathetic, and sensory nerves may get damaged, and there may be a permanent erectile dysfunction for the person even after reducing the priapism. So these are the types of erections, friends. That is psychogenic, reflexogenic, nocturnal, drug-induced, vacuum pump-induced, and priapism. So with this, I think I have completed all the uh, parts of this, that is the functions of the penis, erectile tissue, physiology of erection, types of erection, and sexual dysfunction. So thank you very much, friends, for your patience listening. I thank IJC people for giving them an opportunity to address you people. I think I thank Faraz and the Nishchita for continuously contacting me to see that this semi webinar you will be successful. And friends, if there are any questions, I'll be very happy to answer. So over to for us for the further deliberations.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session is going to help all the participant doctors on their practice. Sir, we have received some questions, sir. If you allow, can I
Yeah,
take this
please.
question?
Yeah. I have got
Yeah,
plenty
the
of time.
first, yeah, sir, thank you. The first question is that what are the factors involved in contraction, relaxation of the penis in ED?
Yeah, it's a very good question. See, in erectile dysfunction, there are four types. That is, the first type is psychogenic erectile dysfunction. Here, the psychological part plays an important role. As I told you, the during the explaining the types of this one, there are four types of erection: psychogenic, reflexogenic, nocturnal, and this so and so. So, psychogenic erection is caused by the psychological factor. So, in erectile dysfunction, if there is a psychological factor, if the mind is not working properly towards the erection, and if the person is not interested in the sex, or he may have some avulsion or aversion towards the sex, then he may not get the erection at all. Or if he doesn't like the partner, that is sexual partner, he may not get the erection. That is psychological erectile dysfunction. The second one is neurogenic. That is nerves. If there is a damage to the peripheral nerves during diabetes, or damage to the nerve bundle during spinal cord injury, or any nervous system problem right from the brain up to the last tip of the nerves, that is either somatic or sensory or parasympathetic or sympathetic nerve bundles, then the erection may be incomplete or it may not be there. That is called as the neurogenic erectile dysfunction. That is due to failure in the nervous system. The third one is hormonal. If there is severe hormonal imbalance, if there is low testosterone, and if the adequate no, the hormones are not there, if the prolactin is very high, if there is hypothyroidism, if the FSH and LH levels are abnormally high, then that is the hormonal imbalance may cause erectile dysfunction. The fourth one is vascular. In vascular erectile dysfunction, there are two types: arterial vascular dysfunction and venous vascular dysfunction. In arterial vascular dysfunction, the blood supply to the penis may not be adequate. If you do the color Doppler of the penis, the blood flow to the penis may be less than 30 millimeters of mercury per square per cc. That is the real blood which is has to go is not going. That is the reduced supply to the penis. That is called as arterial insufficiency. The second type of vascular cause of erectile dysfunction is the venous erectile dysfunction. That is, the venous vein failed to contract during the erection, and there will be venous incompetence. The blood which is gushing into the penis comes back to the mainstream, and here the veins they don't contract, and they just let the blood flow freely back to the system. That is the venous leakage, what we call in ordinary terms, or in technical terms, in the radiological, that is sonological terms, we say venous incompetence. This can be easily detected by colored upper penis after giving PG1 injection. Once we give the injection, when we see the scan the patient after 10 minutes, 20 minutes, and 30 minutes, the blood starts building up in the sinusoids and the pressure goes up, and the peak arterial pressure may go beyond 30, 35, even 40, 50 millimeters of mercury per square centimeter. That is the normal, this one. And in arterial insufficiency men, this won't reach, it will be less than 30 mm. And venous return should not be there during peak erection, that is at 15 to 20th minute. In the patients who have got venous incompetence, there will be reversal flow, that is in the diastolic this one, the blood will be leaking, and the blood will be coming back to the mainstream, and it will not be retained in the penis. That is, the diastolic flow will also be there. That is called as the venous incompetence. And the other one, the last one, is arterial of course, I have covered the vascular, neurogenic, hormonal, and psychogenic. So these are the four types of the erectile dysfunction.
Okay, thank you so much, sir, for explaining it really well, sir. I hope that participant have received his answer. And I can see another question, sir. What should be focused on the medical and surgical history in the evolution of ED?
Can you repeat the question?
Yes, sir. The question
I'll
is
5 minutes
that,
call back.
yeah,
Yeah,
what should
sorry.
be the
Yeah,
focus of the
please repeat the
medical
question.
and Yes, sir. The question is what should be the focus medical and surgical history in the evolution of ED?
Very good question. The medical evaluation should be that is whether he has got any psychological factor, or he has got any neurological factor, or hormonal factor, or vascular factor. All this can be evaluated by taking detailed history and doing relevant examinations, that is hormone test, the blood test, and color Doppler penis. These will rule out the four types of erectile dysfunction, that is refluxogenic, neurological, vascular, and psychological. Coming to the surgical types of erectile dysfunction, detailed history of taking whether he had met with any accident, any surgery, pelvic surgery, or radiation, or chemotherapy for any prosthetic cancer, or any pelvic injury during childhood, bicycle falling, or motorbike injuries, or injury to the head injury, or injury to any part of the body which can cause the nerve damage to the brain or the spinal cord or the nerve plexus to the penis. So detailed evaluation of the surgical nature and scanning of the spinal cord, MRI brain, MRI spine, and MRI the pelvic organs may evaluate the and rule out the neurological causes, that is surgical cause of erectile dysfunction. Mainly we have to take the history of either the person has undergone any prosthetic surgery or urethral surgery, or surgery during the childhood for the penis due to hypospadiasis, or testicular injuries, and removal of the testis, that's orchidectomy. All these things have to be ruled out. That can be done by detailed evaluation of the surgical history.
Okay, thank you so much, sir, for answering it and explaining it really well, sir. We will be taking last question for today's session. And the question is from Dr. Raghavendra, and he is asking, how
Yeah.
is ED managed in patient with hypogonadism?
It's a very good question. I told you, hormonal type of erectile dysfunction. When there is hypogonadism, testosterone will be very low. So we have to measure the all the hormones, direct and indirect sexual hormones, that is FSH, LH, prolactin, T3, T4, TSH, estrogen, and progesterone and testosterone, and measure these hormones, find out the real cause of hormonal imbalance. And if there is a testosterone deficiency, we have to give the testosterone in the form of tablets or gel or patch or injections, depot injections. Usually depot injections are best. They are of two types, long acting and short acting. Short acting testosterone injection have to be given weekly once or 15 days once. Long acting injections, testosterone depot, can be given once in 12 weeks or 14 weeks. So long acting injections are better. Apart from that, gel and patches are available. They're inconvenient to take because one has to take daily. Now, oral tablets are not advised because they are not properly metabolized in the liver. So oral testosterone therapy is not indicated, and it is not advisable. The best ones are gels or foams or creams or patches. The ideal will be the injections.
Okay, thank you so much, sir, for answering all the questions, sir. I hope that related to this topic, all doubts of all the participant has been cleared, sir. And I can see, sir, there is no more
Yeah.
question from the participant ends. If you allow, shall I conclude this session with all your
Yeah,
permission?
yeah. Thank you. Thank you for us.
Yeah,
Thanks all the
yeah,
participants, all
welcome.
the fellow colleagues, and also thank the IJCP, all the authorities for making this webinar a successful one. So we'll come out with a next topic next week. Till then, take care. Thank you. Bye.
Thank you so much, sir. And one more thing I can see, sir, there is a one feedback from Dr. Mohan Lal. He has written very well explained and thank for the presentation.
Oh, thank you. I am really honored by the words. Thank you very much, Dr. Mohanlal. Your
Yeah,
feedback will encourage us to give better and better
yeah, yes, sir.
presentations. Thank you.
Thank you
Thank you.
so much, sir, once again, sir. And till then, take care of yourself, sir. Hope to see you again, sir. We are closing here. Thank you
Thank
so much,
you.
sir.
Thank you. Thank you.